All right, welcome all here to our 15th Journal Club on musculoskeletal ultrasound and regenerative medicine. I'm Robert Monaco, your host here, and we'll be having our last session of the year covering blood flow restriction on that. And thank you again for all the programs helping out with us. We're now up to 20 programs here. We've added Lehigh Valley Network and Buffalo as well. And a big thanks to St. Luke's this week as our featured fellowship program. St. Luke's has two fellows, and they will be helping us present today on the blood flow restriction, going over a few different articles on that. A bit about today's format, slightly different from our other journal clubs. We'll be breaking it down into sections with questions and answers from our panel. Our first section will be on the mechanisms of action of BFR, and then we will have a panel interview, which I will get into our panel later, but I'm really excited to have an excellent panel today on this and looking forward to that discussion on that. We'll follow up with a second article on looking at blood flow restriction in different problems, particularly looking at knee osteoarthritis, and talk a bit about tendon problems and its role there, particularly in the regenerative focus. And then finally, as time permits, we'll talk a bit about safety and blood flow restriction for athletes with some of our trainer colleagues here on board, and get into discussion on this as time permits. And I included two articles for your review on that. As I mentioned earlier, I'm really lucky to have Dr. Johnny Owens, a fabulous physical therapist that I've had the chance to take his courses with through the Owens Recovery Science. He is a leader in the field of BFR nationally and internationally with over 40 clinical trials in his portfolio on BFR. He is a consultant to many professional teams in the NCAA, NBA, NFL, etc. You name it, he's probably been involved with them in some aspect on BFR on this. He's also the former chief of human performance optimization at the Center for the Intrepid in San Antonio on that. And he runs also an excellent podcast, which I highly recommend at the Owens Recovery Science on everything BFR topics. I took Johnny's course recently and was really, really impressed by the scientific basis of everything he goes over, and really learned a lot, and really have started incorporating BFR into my own patients, as well as some research that we have and that he's helping us out on. So I'm really looking forward to his input here, and thank you for that. A brief overview of BFR. I want to go over and play this short video.
We began blood flow restriction in the military for a multitude of problems that we were seeing. For one was what we call the limb salvage patient who had really mangled limbs but didn't go to amputation. They really needed a strength and hypertrophy response but couldn't tolerate loads. The other group was folks who had lost pieces of muscle from the blast injuries. That's a very disabling condition. We can't regrow lost muscle tissue, but we worked on a lot of pathways with our regenerative medicine scientists of ways that we could use blood flow restriction to help restore some function after that lost muscle. And then the orthopedic sports medicine injury, your ACLs, arthritis, cartilage injuries were also a key component because we could start the strength and hypertrophy training very quickly after injury or surgery. We use personalized blood flow restriction training as a because we could start the strength and hypertrophy training very quickly after injury or surgery. We use personalized blood flow restriction training as a means to correct something that we've always had a problem with in rehab. Your body has a couple of different muscle fibers that it preferentially uses. The slow twitch, which use oxygen, the fast twitch, which don't use oxygen. So for most things in daily life, for light tasks like you might do actually when you go to rehabilitation after injury, your body's gonna prefer to use those slow twitch fibers because there's really no reward it has to give you. It's not gonna give you extra muscle size typically not going to give you extra muscle strength. And that's a problem because most people after injury or surgery are losing muscle size and strength from that disuse and pain that they're in. When you're forced to use those fast twitch fibers, you typically will get a reward from your body, and that can be increase in muscle size and increase in muscle strength. And that's what most people have to go after when they go to the gym and lift heavier weights or do high intensity exercises. Through blood flow restriction, we reduce blood flow to a set percentage for each individual to allow them to be able to use those fast twitch fibers even at a low weight that you might use after injury or surgery to get the same kind of benefits that you would if you were to go to the gym and lift those heavy weights or high intensity exercises. So blood flow restriction is the application of a tourniquet on the upper limb of either the arm or the leg. And what we do is we get it there and we find what your personalized pressure is through Doppler-like technology and the systems that we use that will find how to restrict the full amount of blood flow going into your limb, and then we can dial it back to a percentage of that blood flow that we want to reduce while you're rehabbing. So once we get it on you, we know what your restriction pressure is and what percentage we're going to use for what your condition is. We have a specific number of sets and reps and rest periods where the tourniquet stays inflated the entire time. And then once you hit those target sets and reps, we deflate the tourniquet. It's a great feeling because it's really hard work whenever you do this, but you did it at a low, safe weight. And after that, you have a brief rest period. And then if you're going after another targeted muscle group, we reinflate and go again. If you'd like to learn more about personalized blood flow restriction, visit owensrecoveryscience.com.
All right, thanks. Sorry for that hiccup. I'm trying to work out these video issues here, but I want to then turn to our journal discussion. We're going to have Dr. Bogdan from St. Luke's discuss our first article. You can see a bit about her background here, and she's going to be reviewing two key articles on blood flow restriction mechanisms of action. The first, the effects of blood flow restricted versus heavy load strength training on muscle strength, a review, and a recent animal model, which really was very provocative in looking at what are the potential mechanisms of action of BFR. And then we'll have a poll after that. But I'm going to turn it over to Dr. Bogdan to share her screen and go from there.
So here's our first article. Like Dr. Monaco said, it was comparing blood flow restricted versus heavy load strength training on muscle strength. It was a systematic review and a meta-analysis. It was performed in Denmark, and it was published earlier this year in the Scandinavian Journal of Medicine and Sports Science and Sports. So from a PICO perspective, the population was healthy and habitually active adults aged 20 to 80 years old. The intervention was using low load resistance exercise combined with blood flow restriction. And that was compared in contrast to the heavy load strength training group. And the main outcome that they were looking at was that the low load blood flow restricted training appeared equally effective in producing gains in maximal voluntary muscle strength when compared to the heavy load group. And part of the reason behind it was their background was heavy external exercise loads can be contraindicated in specific patient populations such as the frail or elderly, pre-op, post-op, and patients recovering from an injury. And so the question they were trying to answer was, could BFR with lower loads assist their gains instead of this typical gold standard of just heavy load training? It was a systematic review and a meta-analysis of randomized controlled trials. It was done through an electronic database system that included things like PubMed and EBSCO, and they used search terms including strength training, weight training, resistance training, blood flow occlusion, vascular occlusion, and then given that they found over 1,000 articles, but several hundred articles, and then they were able to isolate that down based on which ones were applicable. They classified individuals into an untrained or somebody that's doing no physical activity, somebody that was recreationally active doing around 2 sessions per week or more. And then those that were highly active were 2 to 4 sessions per week, but non-professional. And then athletes doing greater than 4 sessions a week. Conveniently, as I looked up athletes and blood flow restriction, Dr. Owens came up as like the 4th image. So we included him there. And then the 2 groups that they compared were those doing high load, which was 60 to 90% of 1 RM, and then the low load was only doing 20 to 50%, and including the blood flow restriction. And then the way that it was performed was having 2 independent reviewers evaluate the abstracts and which ones applied, and then further evaluate the full text. And then they were able to assess and put in the relevant articles, and then they determined the risk of bias. Ultimately, their result included that low load blood flow restriction and high load training were equivocal in promoting similar gains and muscle strength. And despite that large discrepancy in how much of their RMs they were including with their exercise, they were able to show that that was an equal amount in the muscle mass that was gained. And they saw no statistical difference when they did their standardized mean, and had a 95% confidence interval. So that was their main outcome. And you're basically comparing this guy here with a blood flow restriction band on doing his leg press versus somebody doing a high load training heavy leg press. So some of the takeaways were, can and should blood flow restriction be implemented in our treatment plans? Specifically in similar populations such as healthy 20 to 80-year-olds, specifically in patients that are recovering from injuries or pre-op and post-op, the frail and elderly like we talked about. So I included an ACL photo here, rehab. And the conclusion for me was that this study does indicate the usage for this rehabilitation option. And if you're comparing it to a similar population, because it was level 1 evidence and it was a systematic analysis of many randomized control studies, and they took out biases and they took out confounding factors, I do think that this was a strong means indicating the use of BFR when circumstances limit their ability to do heavy load. So that is the first of the articles. And let me just switch to the second one. And our second one was local and systemic effects of blood flow restriction therapy in an animal model. And this was published just in October in the American Journal of Sports Medicine. And this was done with evaluating 4 groups of these typical lab rats. And they established 4 different groups for them. And the first group was just to simulate exercise, who went under perineal stimulation for 2 minutes. And then the repetitive restriction of muscle blood flow used a pneumatic cuff and inflated and did cycles of that, as well as the blood flow restriction group, which had the pneumatic cuff, but also include the nerve stimulation. And then there was a control group, which had none of this performed. Their main outcome that they were looking for was, did this produce similar gains in muscle mass, cross-sectional area, satellite cell density? And basically they were able to, let's see if I can move that out of the way, sorry. They were able to then decide whether or not this mechanism was showing as indicative of using this therapy. So their background was that blood flow restriction therapy had been an increasingly applied measure in athletic performance and injury recovery, and commercialization of this has preceded some of the scientific studies on it as far as mechanisms, efficacy, and safety. And the mechanism was not entirely known when they were looking at this study. And so they were trying to isolate if they could figure out the mechanism based on this study. So their hypothesis, and what's been hypothesized, was that the metabolic stress and mechanical tension during the blood flow restriction therapy is one of the primary mechanisms leading to that muscle gain or that hypertrophy of the muscle. And their method was, this was a controlled lab study with healthy rat models in 4 different groups. And the measures they looked at were muscle mass and maximal contractile force, myocyte cross-sectional area, and then muscle satellite cell density. Their analysis was done on the tibialis anterior, on this hind limb of the rat, and there was no difference with respect to muscle mass and maximum force comparatively in the groups. They also found that the mean myocyte cross-sectional area of the tibialis anterior demonstrated no difference among the groups, and the contractility testing and gross histology demonstrated no difference. And when they evaluated the amount of muscle satellite cell density, they did not find a difference among the groups. Basically, the conclusion from this was that the study did not put a role for blood flow restriction therapy, at least in this animal model that was performed, and they did not see a statistical difference among the groups and their outcomes. This puts you in favor of not using blood flow restriction therapy, but when you're comparing the studies, this is an animal or foundational evidence study versus the first one being a level 1 evidence randomized controlled study on humans. And obviously that would put you in favor of using it as an overall outcome. And that is my last slide. Stop share.
Excellent. Thanks so much for reviewing those 2 articles. I wanted to include both in, even because I think it's very important to understand we're still in the early stages of BFR and really understanding some of the mechanisms of actions that's going on at the cellular level. And we're going to have some discussion of that going on. And let me just share my screen again.
Do we do any comments on the articles now, Dr. Monaco, or we do that later?
Yeah, 1 second. We're going to do that. I want to launch a poll and get a good feel from our audience about what their experience is with BFR. So let me get that poll off for us. And I think that should be coming up for you all. So Johnny, give you a good sense of what our audience, their experiences with BFR, as well as that comes in there, and give it a little bit for people to get their votes in, and then I will share the results shortly on that. But let's start out by talking a little bit about what your thoughts are, Johnny, on this second article. Obviously, I think there's now a tremendous amount of literature on the positive effects on hypertrophy and accelerated rehabilitation with BFR, but I still don't know if we know exactly what the mechanisms are that are ongoing with this, and that's very interesting, I think, as we look at using it for different things, particularly in our end in the regenerative space on that. So what are your thoughts on this, particularly on that second article? And then we'll have other people in the panel weigh in shortly.
Well, so I know Ashish Betty and his lab folks really well, who that article came from, and Tristan Mars, who's also an author on that. He and I have a rotator cuff trial going on with blood flow restriction. That being said, I think that's a pretty poorly done study. Whenever we really look at it, and the working backwards, we already have a lot of this data, biopsy studies that have shown in human models, satellite cell proliferation, muscle fiber changes, whatever, a lot of these things they were claiming to look at. The issue with their study is just the dosage really probably did nothing at all. So there's already rat models that have been done successfully and shown these factors go up. Natsume's probably done the best one that's shown mTOR significantly moves up whenever you do BFR with these E-stim protocols in a rat. But in this study, they did 2 minutes of stim for 0.7 seconds with 2.3 second rests twice a week. That comes out to almost no dose at all whenever you're looking at what you're doing for muscle activation. And so when you see that there wasn't much change versus control, I really think it was just because, I wish patients, because Rami even says, well, we're going to do this twice a week for, I forgot how many weeks it was, because we want to simulate what you see as a clinical model. You would never have a patient come in and say, I'm going to do E-stim on you for 0.7 seconds for 2 minutes twice a week and expect anything came of that. They said it's a 5-minute intervention, but they just put the cuff on and left it on for 3 minutes and then did that little 2-minute dosage. So I think that's one of the biggest problems. And then Natsume's study, so they did 8 to 10 minutes typically, and their dosages were 8 seconds long, which is more typical to a clinical model. And in the Natsume ones, which did show success, they used the same size cup, but used 200 millimeters of mercury. So they probably got pretty good occlusion. And for some reason, Rami chose half of the occlusion pressure. He chose to use just 100 millimeters of mercury. So we don't even know if they were occluding at all whenever they were doing that. So those are some of the problems. And Tristan and I talked about it. He agreed. He was a little sheepish about the study when we first sent it to me.
I was surprised to see these results, even though obviously the model can be questioned, et cetera, on that, but because the clinical experience has been so robust in so many circumstances. What do you think are the biggest overdriving mechanisms that we going on? Or do you think it's more of a growth hormone or myostatin or just a combination of above? For some of our listeners, what do you think is the biggest effects that we're seeing?
Well, I think it's probably a combination of the above. We've seen those go up in multiple, studies from good labs. So that's something that we want to see. We have a paper coming out that does show proliferation of progenitor cells that was done with the Andrews Institute. We just had a paper from one of our groups come out in June that also showed proliferation of these progenitor cells. CD34 is what they measured. We have an interim analysis of an ACL trial at University of Kentucky that shows that same thing. So we see, a lot of the satellite cell activity and the mesenchymal stem cells look like they do go up with this, which is a good driver of growth. Muscle protein synthesis consistently has been shown to go up, and that is one of the main things that in the DoD we wanted to target with our regenerative medicine is if we start trying to regrow lost muscle tissue, we needed a satellite cell proliferation and we needed a muscle protein synthesis spike. And we found from the studies that we saw that both those things were driven by blood flow restriction. Growth hormone goes up, it looks like, without any question, typically, but that's not a real driver of muscle. Growth hormone does collagen synthesis, it does other things, but it's not a main player for anything with muscle protein synthesis.
I think that's one of the most exciting things I can see, particularly on the regenerative side, is it's really has a great potential to really stimulate some of our satellite cells and really work on the from that aspect on in moving forward on really incorporating this with some of the regenerative treatments on that. I know most of the literature has been in obviously the post-surgical side, but I think this has tremendous benefits for the regenerative side, and we need to see a little bit more work on that as we go through. I want to ask Dr. Malanga quickly just on his thoughts about this and with his vast experiences with the regenerative side, if he can give us his ideas on what he thinks about BFR and some of these articles and just some pearls of wisdom from his experience.
Yeah, well, I want to thank everyone that's on this. It's really stimulating. First, humans are not rats or mice. So I would caution everyone to convert what is found in a mouse or animal model to what occurs in humans. You'd be disappointed, or the history of that is very disappointing. Number two, the insightful thoughts by Dr. Owens regarding that article points to the problems with many articles that are published, meaning that you have to do a deep dive into the article and you can't just look at the headline, the title, the abstract, and feel like you know what's going on. But unfortunately, that's what 90% of people that peruse articles do. And thus the orthopedic community will look at that article and say, yeah, that doesn't work. Because look at this great study, right? It looks like a really great study. And as you know, I've written multiple letters to journals on the stem cell side or regenerative medicine side, where the headliner looks very negative, but if you look at the article, it is very poor. Although on the surface, it looks like a great study, randomized controlled study, et cetera, et cetera. And Dr. Owens also points out the importance of dose, even in this type of intervention. And we know in other simple things like antibiotics and other things, that dose is highly important. Underdosing, overdosing will lead to problems. So I would be careful with throwing around terms regarding quote unquote stem cells, regarding things like this has CD34 or CD45. People use those terms indiscriminately and they really don't know what they're talking about most of the time. I would agree that there is something intriguing about BFR as a stimulus. And if you look at ischemia in general, it is what your body will stimulate for a healing response to occur. So I do think it's similar to a medicinal signaling cell, MSC. And so this is a potent way to get signaling of a local cell, the muscle, to start regenerating, if you will, or reforming, which occurs all the time in all of us every day, depending on the stimulus.
Excellent. There's also a nice podcast on the AJSM on this article, which I think goes into a lot more detail. I include the articles. I think we really need to have more research on the mechanisms of action of this in greater detail, and having an animal model that may be effective will be effective in the future for further study. So I think we need to keep doing more work in that area because it's.
I'm going to throw out real quick, Dr. Monaco, from an animal model, we do have an equine model now that we're doing with Dave Frisbee out at Colorado State, and we'll have our first poster at ORS this year. And so from those guys do great work, and we're kind of the pioneers originally with regenerative medicine out there at Stedman Philippon as well. So what we're getting in their terminal studies, so we'll be able to sacrifice the horses and really understand a lot of deep stuff that's going on. And our first study was already promising. We just got funded for 2 more. So I think from an animal model, that's probably the best we have in the country.
That's great, because I mean, in the regenerative space, that's where we're seeing all the work with the vet people is really where we're getting the most really great data. So to see it adding in BFR here, I think is really going to be add a lot to the literature, and those relationships are probably going to be fantastic. Speaking of that, on the mechanisms, talk a little bit about the either contralateral or the proximal effects that we see. A lot of the teaching has always been, really downstream, but I think there can be really good contralateral and proximal effects on that. And the literature's kind of a bit mixed in that. Johnny, what are your thoughts and what's your synopsis of the literature so far on that? So for example, obviously using it in the cuff and some other areas where we really can't get a, the BFR equipment to be upstream of it.
Yeah, the least amount probably of evidence downstream. It just keeps coming back positive, most of the time. There was a couple studies. One showed that after doing squats, if you did low load without BFR, they got stronger, and then they used MRI and re-imaged the glute, and the glute over the training period got 10% bigger in the BFR group at that 20% load. And then there was a study, it was presented at ACSM, we had a BFR symposium where they did squats in one group at low load, and then they did curls. And when the squats, they had either one group had tourniquets on or one group didn't. And the curls they did on one arm weren't with a tourniquet on. So they wanted to see if there was a systemic effect. And they found that with the tourniquet on, there was a systemic effect where when they did the curls, their biceps got bigger and their biceps got stronger. Stuart Warmington, who's a really brilliant physiologist out in Australia, he called bullshit on that study and repeated the exact trial and got pretty much the exact same results. So that kind of was like, well, maybe there is something to systemic. So then we did a trial out at Curlin Job, just doing rehabby exercises. And these were in healthies, hip abduction, hip extension, all your kind of mat exercises, and just wanted to see if there was proximal strength changes. In the BFR group had increased proximal strength changes compared to the control. And then they did the same exercises on the contralateral limb without the tourniquet on in the BFR group, and the control group did the same exercise without the tourniquet. and they saw contralateral strength changes in the BFR cohort, but not in the control cohort. So that's kind of where we are now. We're about to have a rotator cuff or a shoulder study come out that showed increases in muscle size and muscle strength and EMG activation in the BFR cohort compared to controls. That got us funded. We have an MLB study going on right now looking at that same protocol with college and professional baseball players. And we have multiple other kind of proximal trials going on, the label trial at Rush and et cetera.
Yeah, what I see, I think in some of the PT community, is a lack of picking it up for proximal problems. I look forward to that literature and see, because it's mostly used, obviously, post-surgical ACL, et cetera, where obviously the literature is robust. So hopefully we see more of that, because I do think the systemic effects and the proximal effects, even contralateral, really can be helpful. So hopefully this becomes more mainstream and not on these select cases where, it's a no-brainer and incorporates into the daily kind of PT focus on that. I want to ask one of our other therapists on the panel, Natty, to kind of comment on his use of it and what he's seen and how he's used it in our community and the community around us, and get his thoughts on that as well on the articles.
Hey, good morning. So thank you for having me here. I'm super excited to be here. So I actually been following BFR for quite a while since I first started career in PT, and has been listening to Dr. Owens and his research since I was in PT school. So I can't speak for all PT clinics out there, but within our clinics, we've been utilizing BFR since day one post-op, and what we're trying to do now is really incorporate it as part of as part of the option for our patients. So we have someone that's come in BFR post-op, but now as soon as they transition into return to sport, during in-season, people would frequently come back in and ask if BFR was an option for them to mitigate the stress during the in-season. And I think this concept came to me when I first watched the ESPN special regarding BFR when they did with Dwight Howard. So we utilize that same principles where we get patients to come in season. This is prior to them even be considered injured, right? What it's hard to prevent injury when it comes to contact sport, but what can we do to educate our patient from a neuro re-education standpoint? And I think by utilizing BFR, we're able to elicit that feedback and create that stimulus response for them, so that they can get the benefits of the growth hormone and the muscle protein synthesis while they are playing in season. And because of that induced fatigue response that BFR elicited, it gave them such great feedback as far as their body awareness and what they need to do to protect themselves under fatigue.
Sounds great. I think what we're going to do is kind of move along and talk about using BFR in different conditions now, particularly in arthritis as well as in tendon problems. We know the literature is very clear for muscle hypertrophy, but let's talk a little bit about that and introduce our next speaker, who's going to be reviewing the next article on that, and that's going to be Dr. Diller. He's going to take it over and talk a little bit about blood flow restriction training and its effect in knee osteoarthritis as a use of that, not something we would normally think about it with. And I'm going to turn the screen over to him to discuss this article.
Thank you, Dr. Monica. All right, can you see my slides? All right. So the paper I'm going to discuss was published in Sage in June of earlier this year, actually. the blood flow restriction training effect in knee osteoarthritis people, a systematic review and meta-analysis. So just a little background, as we know, knee osteoarthritis has a high prevalence. Exercise has been described as a treatment for knee pain secondary to osteoarthritis. Benefits are thought to be achieved at around 60 to 70% of the max rep, but patients with knee osteoarthritis experience significant discomfort at that level. So what blood flow restriction allows us to do is to experience the same benefits, but at as low as 20 to 50%. And this was the first systematic review that has investigated blood flow restriction effects in subjects with knee OA. So the population that was being studied was patients with knee osteoarthritis, both diagnosed and with symptoms. And the intervention was blood flow restriction. And the control was essentially technically low load training without blood flow restriction. The outcome was blood flow restriction therapy can be used in rehabilitating patients with knee osteoarthritis. So the methods, the type of review it was a systematic review and meta-analysis of randomized controlled trials using PRISMA guidelines. Some of the keywords they use: therapeutic occlusion, resistance training, knee OA, blood flow restriction, gyatso training. They pulled 465 papers, and after screening and exclusion, they included 5 articles. So the inclusion criteria that they used was that it had to be randomized controlled trial. Like I said before, participants had to be diagnosed with OA or have the symptoms. The intervention was blood flow restriction strength training with low load, and outcomes, the measure of strength and mass, the muscle, pain and discomfort during and after exercise, the knee's functional capacity and quality of life, and then the comparisons was blood flow restriction versus conventional high load training, and blood flow restriction versus excuse me, low load training. So major findings. When compared to low load training alone, blood flow restriction demonstrated more effective gains in muscle volume and strength, and blood flow restriction during a period of 4 to 12 weeks yielded similar strength results to high load training and a greater result as compared to low load training. Low load training showed lower results in terms of muscle volume compared to blood flow restriction with low load training and compared to high load training, but no surprise there. And then Burke et al. Showed that blood flow restriction group had less significant joint pain during exercise when compared to the high load training group alone. Some takeaways: blood flow restriction can be used as a strategy in rehabilitation of patients with osteoarthritis due to the gains that we see with in terms of strength and volume with low mechanical stress. BFR's application must be safe and individualized. I think one paper that was included talked about using pretty high pressures for everybody, like up to 200 millimeters of mercury. So it needs to be an individualized process. And the recommended treatment that the study is putting forth, even though there was pretty high heterogeneity, it's that BFR should be considered in patients with knee osteoarthritis if an individualized program can be administered by an experienced healthcare provider trained in this modality. So my conclusions, I'd consider utilizing BFR in select patient populations. And we're pretty lucky at St. Luke's. We have a couple physical therapists who are trained in BFR. And so I would consider it at this point for select patients. Grade score, I'd say, would be moderate to high because it was a systematic review of randomized controlled trials. So.
All right, thanks so much for that. On that, I think that's going to lead us into our discussion on other topics of BFR that we want to go over. I mean, currently BFR right now is so much used in the for muscle hypertrophy, but I think it really needs to be expanded in its use in tendon use as well as in osteoarthritis on that. So I launched a poll there, and a lot of our audience has not had a lot of experience with BFR based off the last poll, and most of them are not using it in other conditions on this. And I think they think the data is not out there yet and really looking for other things. Johnny, what are you seeing in terms of its use for non, beyond the ACL kind of group and in muscle hypertrophy group and getting it past, the colleges and pro and into the general clinic and use for other conditions? Are you seeing it picked up on that? And what's your take on that?
Yeah, so it's moving in that direction. I think we have a really large diabetes trial going on with the German healthcare system, and so our primary aim on that one is in strength hypertrophy, is seeing if we can control glucose levels better after they've completed this BFR intervention. We just finished a Parkinson's trial with Baylor in Texas, where we were not looking for strength and hypertrophy, although that was measured, but we were looking more of what does it do to the vascular system in those individuals, and found that it improved endothelial function. So I think we're really moving that direction. I think the elderly population especially is probably going to be the biggest winner from what we're starting to see. We don't have it on here, but Chris Sentner out of Germany, their systematic review and meta-analysis that looked at just the elderly studies with BFR, they had the biggest effect sizes we've seen of any systematic review and meta-analysis yet. There's been 33 done on BFR, and that one, the effect sizes were close to 2 for strength and over 2 for hypertrophy compared to low load alone. So I think it's promising. These NEOA studies were also kind of fraught with some issues. So I think the data could have been much better, but one huge problem in every one of these studies, they didn't increase load one bit throughout the entire trial. And so BFR works at 20 to 30% of a rep max. That's just kind of, it's like wheelhouse where it lands perfectly. And so if you're doing an 8 to 12-week intervention and you're not reassessing and increasing people's loads, eventually that rep max gets down to like less than 10% because you're hoping they get stronger. So any of these interventions where they don't reassess and increase load in a chronic study is nowadays is going to have a hard time getting through review. And that paper he pointed out where they used 200 millimeters of mercury of pressure, that was from Segal's group. They used that pressure and it showed good changes in females. And then they used that same pressure and it showed not good changes in males. And the problem with that is the males needed probably more pressure because they had larger limbs. So that's why we personalize pressures to every individual. Every individual's pressure that they need is going to be different. And there's multiple factors. Limb size is one of the driving factors though. And so part of why Segal's second paper didn't do as well is he just didn't personalize it, we think, and he didn't increase load.
I think some of the key points particularly for our fellows coming out on this is that one, this should be thought of as a concept, as a staple of physical therapy on how to get activation of the whole neuromuscular system of that. And it's based on load principles. You have to move the load up to really get effects on this. And this is really important, and it should be used pretty much in multiple conditions. It's not really restricted to that post-op patient. I think too many of us on the physician side see it as that. And so we put this article on OA out there because I think it's really underutilized in this population. And I think the studies really, the global studies are really moving to using this as a treatment, even as a home treatment or an exercise-based treatment for elderly, for sarcopenia, and really just to get activation of a lot of the whole neuromuscular system. So I think we have to change the framework on it. It's been started obviously with athletes and thought of that way, but I think it has to be moved to that general population. And I think it's going to be explode when that happens. And obviously, we're waiting on more literature on that. That second principle is really moving the load up and getting the right cuff pressure. And that's, I think, one of the reasons why I think the Delphi system has been used the most, and it's the standardized one. We really need to have an idea of what the cuff pressure is and monitor the patient and follow a course in moving forward on that. Can you talk to us a little bit about that cuff pressure and what you find and some of the downsides of BFR have been discomfort? What is that sweet spot? And I'll bring in our other therapists to kind of chime in and also some feedback from the audience on that, and talk a little bit about the Delphi system, Johnny.
Yes, so we just put a position stand out. It was just a bunch of us BFR researchers from around the world, and it was in Frontiers in Physiology. It's open access, and kind of like these are what we think are the guiding principles for research with this, as well as for using it clinically. And one of it was we need to start personalize this to every individual. So you're not cheating them on efficacy, and we're also being safe with it, because Grandma Smith might need a lot less pressure than JJ Watt does, and so we want to make sure we're dialing that in. So we use a Doppler-based system within these Delphis that'll find that limb occlusion pressure at 100%, and then we dial it back. In the lower extremities right now, best guidance, it looks like around 60 to 80% of arterial pressure is kind of the best target. Stuart Warmington's group just put a paper out. They used 40% limb occlusion pressure on the thighs and did exercises and measured all these acute kind of factors that we think are valuable for BFR. And 40% did no different than just low load exercise alone. 60% was significantly better. 80% was significantly better than 60%. So if you can get them to this 80% limb occlusion pressure in the lower extremity, we think that's kind of the place to go. The upper extremity doesn't seem to tolerate those pressures as well. And Jeremy Lineke's lab at Ole Miss has shown kind of in the upper extremity, we don't need quite as much pressure. And it might be just because there's less muscle mass to deal with. But he has shown that 50% in the upper extremity did as well for strength and hypertrophy as 90%. So most of our guidance in the upper extremities, we're kind of working at 50% limb occlusion. Jeremy did show, though, that some of these vascular changes, angiogenesis and stuff that we're looking at in the upper extremity, didn't happen at 50%, but it did at 80%. So maybe if we're going after a different target than strength hypertrophy, we might be dialing our pressures up differently. And I'll point out in that OA systematic review and a meta-analysis, they completely mucked up the guidance with tourniquet cuff widths. A wider tapered tourniquet cuff is the safest cuff. You use less pressure whenever you do that. It's typically tolerated much better. They said that you should be using thinner cuffs because they're tolerated better. They even misrepresented one of my articles in there. And what happened is a thin cuff needs a lot of pressure to occlude. In some of these early studies, they screwed it up. So they used a thin cuff at 200 milliliters of mercury and a wide cuff at 200 milliliters of mercury and said, which one's harder, which one hurts more? Well, a wide cuff at 200 milliliters of mercury is putting a lot more pressure, but it's actually occluding. So you would have to personalize those two different cuffs. You can't just use a standard, let's use 200 with a thin or 200 with a wide and say which one's harder, because to actually occlude, you're going to need a lot more pressure to even get to the artery with that thin cuff. So that's the guidance is a wider cuff is the best way and safest way to go.
I think it's really important to emphasize that that as physicians here, a lot of us in this who are fellows don't have experience with this. Really work with your therapist. You have to get the right occlusion pressure. They have to be moved forward in terms of their load, and then you have to have the right frequency. Speaking of the frequency, Johnny, do you find that how often a week, what is the sweet spot of this? Because I see some of our therapists do it once a week and do a low load on it. They kind of add it as this adjunct versus not as kind of overall the main focus of the therapy. What is the sweet spot about the frequency of doing it and on that you're finding?
Yeah, so you can look at it as a surrogate or substitute for high load training. And so typically a high load training, if you're talking strength hypertrophy, you're going to need more volume than one time a week. And so Jeremy Lineker, again, they did a systematic review and meta-analysis and looked at the studies of if you're loading in this 20 to 30% rep max, what really seems to work, and 2 to 3 times a week had the biggest effect size. It actually had a bigger effect size than daily when you're loading. But whenever we see that you're not loading, so using there's been several studies now, and actually a really good one just came out of Denmark that showed this as well. Using no load, just putting the tourniquet on and basically doing nothing, the ischemic preconditioning model has shown to stave off atrophy, and it looks like it slows down the catabolic pathways. Primarily, the biggest one that it hit was MRF1, muscle ring finger 1. Those studies that have shown slowing down atrophy are daily, unfortunately. So if you're using almost no load at all, it looks like the frequency has to be pretty high. If you get to 20 to 30% of a rep max, or they are starting to load, you're probably safe doing 2 to 3 times a week. All of our clinical trials are basically at twice a week. You can never get these clinical trials, get people to come in 3 times a week, unfortunately.
Yeah, I think that's the key there is really when you work with your therapist and having a prescription for the right amount of load and the right amount of frequency to really get effects on this is really critical. They really need to incorporate this on at least twice a week, I think, in the early stages. And then obviously BFR is really a tool to be used until they can get effective higher loads to the area on this. So use it early on and use it correctly at the right dose is really, I think, the key here. Johnny, can you speak a little bit to your experience with its use in tendons or regenerative, and where you see it going in your experiences with some of the professional athletes and how it's being used on that?
Yeah, so there was a tendon study done several years ago out of Japan. And they showed, compared to high load training, BFR didn't help the tendon at all. And that kind of created a shit show, because then everyone said, well, we got a steroid issue here where we're getting all this strength and hypertrophy, but we're not seeing tendon adaptation. And then again, as Dr. Malanga pointed out, you have to kind of look deep into these studies sometimes. And this study, they did heavy load and they increased the load over 12 weeks. They reassessed and increased it every 2 weeks. For some reason in the BFR group, they never increased the load in that tendon group. And then they used a really thin kind of pump up band, which we just find don't really work. Because our hypothesis was, well, if you drive lactate, then lactate will drive growth hormone, and growth hormone does collagen synthesis. So they say, we're going to create lactate with blood flow restriction, and that will do collagen synthesis. And there's a paper came out, this band called a B Strong, which is similar to what they used, did not increase lactate one bit. It didn't do anything different than low load. So they kind of messed it up on 2 sides. So then Chris Sentner out of Germany just put a tendon paper out where they did increase load every 2 weeks in the BFR group, as well as in the lifting heavy group. And this is looking at the Achilles tendon. And they use the same systems that we use, so a wider tapered cuff and everything. So we're pretty sure they were able to get that lactate response. They did show equal increases in Achilles cross-sectional area and Achilles stiffness in the BFR group and the heavy load group, almost identical kind of gains. And control didn't. And their hypothesis was not only is this lactate and then growth hormone response that drives collagen synthesis may be beneficial for tendon, but also this hypoxic effect, as again, Dr. Malanga has pointed out. Hypoxia is a driver of a lot of things. The Nobel Prize last year for physiology was given for work in showing hypoxia pushes gene expression. And so hypoxia looks like it can increase tenocyte proliferation, and this increase in tenocyte proliferation might be what was valuable for the tendon. We've seen success. One of our really good success has been with lateral epicondylitis. Surprisingly, that was because so many of our trigger pullers in the military, lateral epicondylitis is just a huge problem, and we were seeing a lot of anecdotal success with that. We have submitted a grant in the military to have a study for that. We do have a study ongoing at the Cleveland Clinic and a study for lateral epi at NYU Langone, because they were also seeing positive pilot data with that. So I think there can be something there with tendon, more, obviously more to be kind of fettered out here, but potentially growth hormone can drive collagen synthesis, which is beneficial, and maybe that hypoxic effect can drive tenocyte proliferation.
I would echo that. I in my review there, I think the hypoxic mechanisms are really the key to the stimulation here, and I think this will pan out to have an excellent effect on tendinopathies in there, as well as helping with load management principles on there. So I think it's going to be a staple of the treatment for tendinopathies and tendinosis in the future. And I really encourage our therapists to use it within that realm, particularly when we're doing regenerative treatments with that. I think it has a tremendous effect that I think I've seen in my patients, as well as with the literature on this, which is still evolving on that. There's a few questions I want to go over and see if our panelists also can offer more insight. One on the safety. I put up some things in our poll, and we included an article. This is very, very safe to use on that. I encourage you to read the articles on that. There are a few contraindications we're not going to go into on this, but for those of you who are unsure, in your poll results, this is very, very safe. Read that article, and there's very limited restrictions that you really see on this, and most patients will qualify on that. There was a question on quickly on COVID, and I know, Johnny, you've done a lot of work with that population now, and some have putting out some publications on that. Is there restrictions in BFR in people who may have had a COVID exposure due to some of the hypercoagulable states that they might have? Are you seeing anything on that front, or any changes where BFR might be contraindicated?
Well, we haven't seen really any issues with hypercoagulability, and the studies that have looked at does BFR increase coagulation factors after one bout, nothing has shown that it increases that pathway. And then chronic training trials where they looked at that, does BFR increase any coagulation? Hasn't shown that at all. Our first RCT in the military, we did bilateral duplex ultrasound scans after doing BFR post-surgically for 4 weeks on people, and didn't see any signs of any differences between groups, or so really no issues there. So it wasn't really from the coagulation side. It was, yeah, is it safe? Can people tolerate this? And we just had a study come out that showed BFR really did a strong proliferation of the ACE2 receptor. And so the question became, well, if you drive a lot more ACE2 in individuals, are you opening up, because that's what COVID attacks, is that pushing more potential for COVID to go after that? So that's a question we don't know, but we do have some studies that looked at, should you take people off ACE inhibitors that had COVID, and they showed that, it doesn't look like you really should. So we think that's okay. If you increase ACE2 activity, you're reducing oxidative stress, because that breaks down that angiotensin-renin, oxidative stress pathway. And if you have less oxidative stress and less endothelial damage, then potentially you have less coagulation, and it could be a benefit. So if we're helping the endothelium and also giving these people some strength and hypertrophy after they've been in the ICU or been in the hospital, that's a win-win. The ICU patients in general are ignored from rehab side. I think it's like greater than 70% have this long post-intensive care syndrome, with strength losses and function being one of the biggest drivers of their disability long-term in life. So I was on this COVID international task force, kind of looking at just what should we do from a rehab side with people that have been in intensive care for so long. Unfortunately, it's always a payer issue.
Yeah. So I think that really brings up this. This is a technology that should be used, across the board in physical therapy, and not just for athletes. But there's tons of data, and for us as team physicians on this podcast. Also recognize that, BFR principles are being used for both performance and recovery. There's a lot of newer literature coming out in this space. And I think as a technology, having hypoxic episodes with exercise and its effect on performance and muscle in general is something to keep a close look at. Athletes are usually way ahead of the general population. So you're seeing this picked up a lot, and you need to be familiar with this as well as it going on in your athletes for training purposes as well. There's the last question on how to find good therapists who do BFR. Johnny, I know obviously you have a certification on there. Do you have any words of wisdom about kind of working closer with the PT community on how we can, as physicians, work closer to find people who are doing good BFR and understand these principles? What are the resources as physicians we could go to?
Yes. Well, we have an easy resource. If you go to our website, we have listed, not all of them, but people who want to be. We have certified providers who are doing it, who've gone through the training, are using the equipment that we think is the safest. So you can go on there and just look in your community. We have patients or surgeons reaching out to us all the time asking, hey, who do you have in LA or Miami, et cetera. And we just send them to that site, and they can pick someone close to them. So we do have a list of all those people there, and we're seeing it. Our system and our people who are trained in every professional league, BFR is now in workers' comp for the NFL, NBA, NHL, MLS, MLB. So any pro athlete that gets hurt, their surgeons are typically, if it's a limb injury, are writing prescriptions to get their athlete one of our systems and get them trained. So many of the orthopedic team physicians are exposed to it now. We're really seeing a proliferation kind of in the communities from that, because mostly ortho docs are asking that we work with these teams. When I do my surgeries, who do I send these people out to in the community?
Excellent. So last closing words. I'm a bit over our time, and I thank everyone for joining us, and I particularly thank Johnny for joining us and giving us his insights on BFR. It's such a key area, I think, in rehabilitation, and as team physicians and fellows are going through education, this is going to be a staple of rehab principles moving forward. And during my career, you come across a few things that really change things significantly, and BFR, I think, is a game changer in the rehabilitation community, and I think it's going to continue to grow, and it's going to grow in the performance side. So we want to thank Johnny and the rest of the panel for their time, giving us some insights. We just scratched really the surface of what BFR is, and I've included a bunch of articles for you in the supplemental reading that you can read about, and keep your eyes open and learn more about BFR, because I think it's a key feature as you prescribe rehabilitation treatments for your patients and moving forward on that. So we look forward to hopefully having him back another time on that and to discuss this more. And thank you again, and thank you panelists for this quite enlightening discussion on that. Our next journal club is going to be next week, and we'll cover board review questions if I get that going. So be on the lookout for some emails on that. And again, I thank you. Have a safe and a good weekend on that. And thank you, everyone. Bye-bye.
Thanks.